everyone can see my screen.
We can.
Awesome. So this was a presentation that I developed in partnership with Esther DeCare, who is one of our cardiac intensive care unit nurse practitioners as well, who has a background of working in the neonatal intensive care unit, and with two of our nurses on the unit, Shauna and Michelle, who are working with me to become neurodevelopment super users on the unit. So I have no conflicts of interest to disclose. So really the objectives for this section are to understand the CHD brain, which we have discussed in the past, so this will just be a brief overview. Really talk about the need for neurodevelopment in our population, and I'm hoping to really start changing people's perspectives on neurodevelopment, in that it shouldn't be a nice to do thing, but really changing the perspective to think of neurodevelopment as a form of neuroprotection for our patients. And we'll focus mainly on skin to skin holding and modified kangaroo care and proper positioning in critically ill neonates. So this is something we discussed last week, but essentially in critical congenital heart disease, we know that babies born at term have brains that are immature by up to 6 weeks gestation, and that's generally, in the brain volume and the white matter volumes and microstructure as well. We know that the immature brain, similar in children with congenital heart disease and babies born preterm, is vulnerable to injury. And then when we kind of look at this overall picture, this is an overall important factor in long-term neurodevelopmental delays, is this immaturity of the brain. So when we're looking at our babies with critical congenital heart disease, their brains are more looking like this 33-weekers brain, smaller, less cortical development compared to this term baby that has a larger and more developed brain. So when we look at, our babies in the cardiac intensive care unit versus our babies that, are going home shortly after delivery, you can see that there's a very big contrast between the two different environments that we're seeing. Babies in the cardiac intensive care unit are surrounded by invasive machines, lots of noise, lots of lighting, lots of painful procedures, compared to the baby that gets to go home right away, gets to spend time with parents, bonding with both parents, in a comforting environment that's full of lots of love and positive touch. So you can already kind of see this difference of how the environment is drastically different in our babies that are critically ill versus the babies that are well. And we think of how this can impact the brain development and how can we modify this or implement certain strategies to minimize the effects of the ICU environment. So when we look at the first 72 hours in the ICU, we can see that the majority of the touch these babies are getting, up to 92% of all touch is negative in these babies. And they're undergoing multiple procedures, intubation, suctioning, getting an NG tube insertion. They're undergoing surgery, even things like auscultating their heart sounds or their lung sounds with a cold stethoscope. Having their blood pressure checked every couple of hours. These are all associated with negative touch and have pretty big impacts on how the baby's brain develops over time. So this really means that only 8% of all the touch that's given in the first 72 hours of life in these babies is actually positive touch. And usually that's not given by us, the healthcare providers. This is really provided by the parents. So it kind of highlights the importance of involving parents early on and giving them the appropriate education and reassurance on how to provide comfort touch and things like holding and breastfeeding, things like massage as well. So let's just talk a little bit about neuroprotection. So neuroprotection in general is actions taken to preserve neuronal structure and or function. And usually we think of neuroprotection as a response to a significant brain injury. So we know a patient has a stroke, so we're going to modify the head of the bed. We're going to do active seizure management, put them on CEG. We're going to think about normothermia or hypothermia, considering things like sedation, muscle relaxing, close blood pressure management, and managing blood sugar closely. And our current neuroprotective strategies are very reactive. Everyone thinks of neuroprotection after a brain injury has actually happened. So what I'm trying to put across today in the message for this talk is that neurodevelopment equals neuroprotection, and promoting brain growth and maturation through neurodevelopmental care, particularly in our babies that are born with immature brains, is actually protective against brain injury. So we need to start thinking of neuroprotection and neurodevelopmental measures before the brain injury occurs. And really, this is in the healthcare provider's hands, particularly the nurse's hands, and how they educate parents and involve parents in the day-to-day care. So some of the proactive neuroprotective strategies we could be using are things like skin-to-skin holding, utilizing proper positioning and good physiologic positioning for our babies, things like oral immune therapy or non-nutritive sucking, breastfeeding, trying to minimize stress and pain, so potentially clustering cares, using sucrose, for example, when there's a heel stick happening. And then along that line, providing uninterrupted sleep, noise control, trying to minimize the conversations that are happening at the bedside and trying to keep the overall noise level down. Cycled lighting as well to provide a nice dark environment for protected sleep. Positive touch, things that are positive for, music, parental voice, reading, those sorts of things. And then really the main theme is that parents should be empowered and involved in the day-to-day care of their baby. So let's move on a bit to skin holding. So just to start off on a bit of history, so skin holding or kangaroo care was actually developed in Bogota, Colombia in the 1970s. And it really came about as a strategy in a low resource environment. They had a high incidence of low birth weight infants, where there was poor levels of prenatal care, and then there were high rates of postnatal infection, high rates of mortality, and then there was also a shortage of staff and equipment. So there weren't lots of incubators or isolettes to keep the babies warm, not enough equipment to support their respiratory needs, etc. So in an effort to lower the rates of infection and to support appropriate thermoregulation, the staff in Bogota encouraged parents to be doing skin-to-skin care and exclusive breastfeeding. And the secondary outcome to this was that they actually saw significant improvements in their neonatal outcomes. They saw decreased rates of infection, decreased rates of mortality, shorter hospital length of stay, and the babies were just overall doing much better. So why should we be doing skin-to-skin in the cardiac intensive care unit? Usually we correlate skin-to-skin or kangaroo care with the NICU population with preterm babies. So why is it important to do in the cardiac ICU? So from the literature that's out there, we know that skin-to-skin care promotes cardiorespiratory and temperature stability. And this literature is coming mainly from the preterm population, but if you just kind of correlate and find the similarities between our cardiac babies with their immature brains and the preterm population, we can see that a lot of these topics are actually very similar, and the risk profile is still very similar in our babies. Skin-to-skin also promotes better sleep organization, so we're having better sleep-wake cycling throughout the daytime. It increases frontal brain activity during sleep, which is an important part of brain development, improves oxygen saturations, lowers airway resistance, so maybe having decreased needs for respiratory support, decreases apneic episodes, decreases the average length of stay, and decreases the risk of hospital-acquired infections. So those were the benefits for the patient, but there's also significant benefits for the parents in doing skin-to-skin care as well. So for the mothers, it actually increases their milk production. So that's supportive of breastfeeding for the babies, and then also for expressed breast milk as well for the babies that can't eat orally at the time. Increases parental-infant bonding. Parents also report less stress and more satisfaction with the care provided. Parents become more responsive to their infant's cues, so they'll know when their baby's upset versus satisfied and what to do to help manage their baby's irritability, for example. Again, it strengthens the family role and decreases feelings of helplessness. This is really common in our families where the baby is very sick and a lot of the care they're receiving is very medical, and the family doesn't know what their role is, and usually they're sitting at the bedside in a chair and they're very disengaged. So this is a way to engage the families and essentially give them an important role in their child's care when there's so much that they can't do for their baby. And then also increases the duration of breastfeeding. So with the increased milk production, the mothers are also more willing to try breastfeeding, even if their child has been quite sick. So who can undergo skin-to-skin care in the cardiac ICU? So we know that even though there are many similarities between our cardiac population and the preterm population, there are some key differences as well, and we do need to keep that in mind. So when we're thinking of our cardiac baby, we should really be thinking of skin-to-skin care for every baby, whether they're pre or post-op. And this should be kind of a routine shift-to-shift conversation or discussion that's happening. And parents should also be educated on the importance and their important role of holding in skin-to-skin care in the treatment and therapy of their child during their admission. So again, it shouldn't be a nice to do thing. It should be educated to parents as this is a part of their therapy and this is an important part of their care. So of course, there are some key important considerations to skin-to-skin care and some contraindications to holding. Of course, patients on ECMO it's not really safe to be having these babies up in parents' arms. If the baby has an open sternum, they also shouldn't be getting up for skin-to-skin care. Umbilical arterial catheters are a little bit more of an unstable line. So the preference is that those lines are visible at all times. So it is challenging to provide skin-to-skin care with those lines. Obviously, if a baby is receiving therapeutic hypothermia, they shouldn't be brought up to parents' arms because then they'll get warm. And that'll essentially do the opposite of what we're trying to do. So babies that are undergoing therapeutic hypothermia should remain in bed. Patients who are muscle relaxed, this usually indicates that there is some cardiorespiratory instability and probably you're actively titrating their inotropic medications or their ventilation. So usually these babies are too unstable to be getting up out of bed. And then also patients with a high risk airway, if there is significant risk for them becoming extubated and it would be a difficult reintubation, then that would need to be further conversation with the medical team about whether it's safe to be taking that baby up into parents' arms. Other high-risk patients we need to consider are patients that are on nitric oxide. If you're actively titrating inotropes, if the baby is on high frequency oscillation or is receiving external pacing, then these are patients that would require an additional conversation. These aren't hard contraindications to skin care, but usually these patients are quite unstable and it requires additional conversation with the team before bringing these babies up for holding. So to prepare for the skin-to-skin procedure, it does kind of need to be considered as a procedure and a therapy at the bedside. So it's important to have a chair at the bedside for parents to sit in. Usually a lot of units will have a comfortable rocking chair or a chair with good arm and back support. Sometimes additional pillows might be needed, so including a breastfeeding pillow or blankets, just to make sure that the baby and mom are both feeling secure. So if you see in this image here on the right, we've used a breastfeeding pillow just to support mom's arms so that she feels stable, especially since the baby's intubated and she didn't really want to move her arms and potentially put that airway at risk. We should get a gown for the parents as well, just so that they can wear it backwards and have the front open so that the baby can rest against the chest. Blankets for draping as well to keep the baby warm. And then also making sure that the parent can commit to holding the baby for several hours. So asking them to use the washroom, making sure that they eat and drink. If the mom needs to pump, encourage her to do all of those things before skin-to-skin care. It's very disruptive for the baby if you're moving them from the bed to parents' arms and then 15 minutes after you have to put the baby back. So in terms of the procedure, have the parent ready and in the gown and have the gown open to receive the infant. And make sure that the chair is in a very easily accessible place beside the ventilator. Usually if your patient is intubated or on respiratory support, it's always a good idea to ask a second nurse or RT to help you with the transfer. If the patient is intubated, a respiratory therapist should always be present to help secure the airway. Sometimes a retape will be required before the baby is transferred to hold. So it's always important to have the RT assess the airway before you're moving the baby over. And then ensuring that all the lines, the transducers, everything is untangled and free to move so that nothing's being dislodged during the transfer. And this is usually what a second person can help with as well. And then ensuring that any emergency medical equipment, such as the ventilator or a suction or your MIE bag is able to reach the infant after transfer. So making sure all those cables are long enough to reach the baby. And then sometimes you can also, if the baby's stable enough, you can temporarily disconnect some of the lines and cables that are attached to the baby. So if they're on feeds or if they're requiring continuous suction for any reason, try to disconnect those to make the transfer easier so that you have less likely of a risk to dislodge anything. So here at SickKids, we're using a parent-assisted transfer as part of our method of doing skin-to-skin. So we do have a video of what this looks like. This was taken by one of the hospitals in the US, but it's a great video to show an example of what the parent-assisted transfer is. So you can see that this mom is putting on a hospital gown. She's wearing it front to back so that there's space open in the front. This mom is wearing a loose shirt, so she's actually going to tuck the baby inside, but some parents might prefer to not wear a shirt at all. You can see that there's an RT. They're ensuring that the airway is nice and secure, and sometimes a retape is required. They're disconnecting all the lines that aren't necessarily needed to help transfer the baby over. And then essentially mom is just leaning over, picking up the baby and putting baby against the chest. The RT is stabilizing the airway, and then she just sits back in the chair that's already available and close by the ventilator. So mom's just going to tuck the baby inside the shirt so that baby is skin to skin. And then they're going to use blankets to, secure the baby, make sure baby is nice and warm. Sometimes a little hat is also nice to keep baby warm. and then they'll secure the ventilator and everyone's happy. So sometimes, as we've discussed, there are contraindications to skin care, and there are some modifications that can be done. So some of the modifications can be included are finger holding. So parents just, holding the baby's hand, or if the baby's awake enough, they can actually grasp the parent's fingers. Hand hugging is also another good example. So that's this image up here at the top. So essentially the parent is putting one hand providing firm pressure on the head, and then their other hand is at the baby's feet or at the bum, and essentially providing gentle pressure with both hands to provide a bit of that comfort and containment for the baby. And then encircling is another example that you can see down here, with the mom essentially reaching her arms around and supporting the baby. And then in terms of really the procedure related to this is, making sure the bed is at a comfortable height for the parent and having the parent settle in a chair. And then just providing gentle encouragement for the parent, because a lot of the time these babies are very sick and the parent might be afraid to touch their baby. So that just encouraging the parent that they're doing the right thing, and giving them gentle pointers on how to support their baby when they're doing things like modified kangaroo care. Encourage the parent to talk or sing to their baby during the procedure. So we'll briefly go over positioning a bit as well. And I'll be talking a little bit about what we call physiologic positioning, which essentially facilitates normal patterns for growth and development by helping maintain midline positioning and flexion of the limbs. It also helps prevent positional deformities, so things like plagiocephaly, where the head gets quite flat from being in the same position for too long. And then also helps with providing boundaries, helping develop anti-gravity movement. And when we provide boundaries, that also provides containment and decreases stress for the baby. And then having good midline positioning and flexion helps develop the normal motor skills, tone reflexes for a baby. So when we talk about proper infant positioning, we essentially have 7 components. We always want to keep the head midline, whether that's in a supine position or a side lying position. You always want to keep the upper and lower extremities flexed, especially in a newborn infant. The upper and lower extremities should always be in a nice flexion position. We always want to keep the hands midline and close to the mouth. This is a good physiologic position for infants because it helps develop that midline strength, and then is really one of the building blocks to babies being able to roll over, and then when they're prone, push up with their hands so that they can start crawling. We always want to make sure the hips are rotated inwards. We want to really try preventing that frog-like position. And then the other piece is having good boundaries so that the baby is nice and contained. So like I mentioned, in a supine position, we always want to make sure that the head and the body are aligned and in midline. We want to make sure that the hands are at midline, that the arms and the legs are flexed. We want to make sure that there's good support at the hips so that we're avoiding that frog-legged position. And then we also want to try to avoid rolls under the neck and the shoulder as much as possible. Of course, if your patient is having issues with airway management, then that might be necessary, but that can sometimes provide a lot of hyperextension of the neck and then shorten the muscles at the back of the neck, which then can result in a torticollis. Side lying position is also really great for our patients and doesn't pose any issues with sternal precautions either postoperatively. This is a nice position because it can facilitate that nice hand to mouth position and supports a lot of that nice limb flexion. It's also a nice position because just from the side lying position, they are avoiding that frog-legged position as well. So here are a couple of examples of poor positioning. So you can see that these babies have poor boundaries. They're in a really frog-legged position. The arms aren't flexed or brought to the midline, and you can see that the heads aren't midline and are turned to one side. And when we talk about poor positioning, they have quite a few impacts to the baby. So from a poor positioning perspective, they can negatively impact cerebral blood flow. It can impact blood pressure, oxygen needs, pain scores as well. It can impact how the baby is able to sleep and rest. And a big thing is impacting the baby's motor development. And when we see our babies long-term in follow-up clinic, usually around 4 to 8 months of age, because of poor positioning, sometimes we're seeing things like the inability for the baby to tolerate tummy time. We're seeing a lot of positional plagiocephaly, which is that flat head. A lot of the babies have disorganized movement as well, and that's due to lack of having that nice midline positioning. And the poor self-regulation and inability to self-soothe. So if you've ever seen a healthy baby that hasn't been in hospital, when they get upset, they start sucking on their hands, and that's one of their ways of being able to self-soothe. And if the baby has never been able to support this position in hospital, then they're never going to learn how to be able to self-soothe. And then this also contributes to overall poor muscle tone. When we talk about midline head positioning, this is actually very important, especially at the bedside. So when you kind of think of your arterial supply to the brain, you have your internal and external carotids essentially going up both sides of your neck. And we know that post-bypass and post-surgery that the cerebral autoregulation is impaired. And the cerebral autoregulation is essentially the ability for the blood vessels in the brain to control how much blood is getting to the brain. So in cases where there's low cardiac output, for example, the body is essentially going to preferentially send blood up to the brain instead of the other organs, because you know, the brain being one of the most important organs. However, when the head is turned to one side, we're actually constricting the ability for the ease of flow on one side of those carotids. So we might actually be kinking those vessels off. And this can result in actually asymmetric types of brain injury. So this is an example of a baby who had a low cardiac output state post-operatively and had asymmetric non-midline positioning of the head. And we can see that one side of the brain, it was actually significantly impacted due to poor cerebral blood flow, resulting in a hypoxic brain injury. So when you're at the bedside, really think about how you're positioning your baby's head and how that actually might impact their brain injury risk, especially during periods of low cardiac output and hypotension. The other thing you really want to think about is your use of restraints as well. So when you're positioning supine, you don't want to be extending your baby's arms completely straight. You can allow for some slack for the baby to bring their arms midline. You obviously don't want them right up in their face because then they can self-extubate, but allowing some of that midline positioning and allowing a bit of slack with your wrist restraints is really important. And then when your baby is in side lying, try not to restrain the upper arm behind the baby's back. So you can kind of see in this image here, this arm is behind the baby's back, which is actually not very supportive of good physiologic positioning. So you can kind of see the contrast between this baby up here and this baby that's lying on the side with both arms nice and flexed and at midline. So I have just a couple of examples of poor positioning, and then someone has gone in and fixed their positioning. So maybe I can get a volunteer to kind of unmute themselves and tell me what they think about this baby's positioning and what they think is good, what they think is bad, and then how we can potentially improve her positioning. Can I get a volunteer?
Yeah, this baby's position is frog-like position. and head is not in the midline.
Yeah, you're absolutely right. So this baby has no boundaries to support. Sorry. So you can see that she's really in a frog-like position. Her arms are extended at the side. There's no flexion. There's no midline positioning. And the head is also slightly turned to the side. So someone came on in here and helped her with her positioning a little bit. And now you can see that she's in a somewhat sideline position, not all the way over, but she's no longer in a frog-like position. She has some nice boundaries around her. So she has boundaries on either side and at the bottoms of her legs to help support some of that flexion. And you can see that her arms are a little bit more flexed and brought to the midline. And her head is also more midline with the rest of the body. So this is much improved compared to the previous image. Does someone want to take a guess at this one and provide us with some of your thoughts on this baby's positioning?
This baby is on a slight left lateral position, and head is in the midline, and arms and legs are mildly flexed and restrained.
Yeah, so this baby is a little bit different. So we can see that the legs are nice and flexed, and someone actually put a roll in between the legs to support some of that flexion. Again, this baby doesn't have great boundaries. So a couple of nice little rolls to support the arms and the legs would be nice. You can see that the upper arm is actually extended and behind her back, which is not great for the shoulder motor development. And then her head is more or less midline. So someone came in and repositioned her a little bit. And now she has good boundaries at the legs and on either side. You can see she has a little bit more slack on her wrist restraint, so she is able to flex that arm a little bit more. She has good flexion in the legs, and the rolls and the supports at her hips are preventing that frog-like position. And you can see that her head is really nice and midline in this position. Great. So this is just for our Sick Kids team, but we have a couple of people that are experts in physiologic positioning and skin to skin, and we have some great nursing resources to help support and model good positioning and skin to skin care. So that's one of the strategies that our organization has taken to train specific nurse super users. And then in summary, so babies, we know that babies with critical congenital heart disease have brains that are vulnerable to injury. And really, I hope that I was able to change your perspective on neurodevelopmental care and neuroprotection, and how that neurodevelopmental care is neuroprotection and should be done as a day-to-day care to prevent brain injury in our babies. We're trying to encourage minimum daily holding or skin-to-skin care in our babies. And we know that proper positioning has significant benefits to our patient, especially in preventing long-term brain injury and motor delays. And then knowing that brain health of our babies is in the bedside nurse's hands, and you have such a huge impact and huge role on helping these babies long-term. Thank you very much. Any questions?
Then for Vanna. Okay, thank you, Vanna. I've heard that a number of times, and each time I really, really enjoy it. So thank you.
Awesome. Thank you. Have a great day, everyone.
So everyone, our next speaker is at 12, and it's Dr.